Namaste. This lecture is for week number 7 and lecture number 3. Today I am going to speak about how to prescribe ENDs. This END terminology may be new for you. It is a short form of essential narcotic drugs. As you know, in palliative care, our patient has moderate to severe pain, and this can be relieved only by use of narcotic drugs, and there are 6 drugs which are essential, defined as a essential narcotic drugs under NDPS Act 2015. So, we are going to talk about how to prescribe these drugs. A quick revision to the history of WHO ladder and how we put the WHO ladder in practice for prescription of essential narcotic drugs, that we will go through quickly. The WHO ladder was WHO established it in 1980 as a part of cancer control program, and in 86 it was taken up as a method for relief of cancer pain. This was specially designed for treatment of cancer pain and a part of palliative care, and in 1996 a revised edition was published. In India, WHO ladder is taught and practiced at all levels of healthcare system as part of cancer control program. So, the basic concept of WHO ladder are 5 principles. It is based on 5 principles. All the drugs in WHO ladder are given by mouth. They are always given round the clock and not on as per requirement. It is given like 6 hourly, 8 hourly, round the clock dosage is given. All the drugs are given as per the WHO ladder. In ladder 1, the drugs are non-steroidal anti-inflammatory and adjuvants. In drug level 2, ladder 2, they are mild opioid, and in ladder 3, they are opioids. Then 4th principle is attention to detail. You must look for the side effects or any complication because of the drug. For each and every patient, you evaluate all the problems that might have occurred because of the prescription of these drugs. And 5th is individualized treatment. Few of your patient may be sensitive to ENDs, or they may be sensitive to NSAIDs. So, as per the patient's body and patient's reaction, you can decide the type of drug you want to prescribe to that particular patient. WHO ladder is widely used across the world, and it has also been translated in the local languages. Like the on left side you will see it is translated in China, and in my setup we had translated it in Gujarati, our local language. Over the period the undergone many changes with introduction of the patches, therapeutic system, and introduction of intervention blocks. The WHO ladder is incorporated all new technology also. So, it is not nowadays, it is not so that all the patients should be given particular drugs which are mentioned on the ladder, but on the way along the ladder, if a patient is fit for neurolytic block, you may give neurolytic block. If a patient is not able to swallow medicine, you can prescribe patch, and of course, psychosocial support to your patient is always be done at all steps of ladder. So, by incorporating this new technology, new drugs and psychosocial intervention, you can definitely improve quality of life of your patient, and that is the aim in any palliative care setup. Firstly, whenever you want to prescribe in END or morphine, The 6 drugs which are essential narcotic drugs are codeine, morphine, methadone. These are the 3 available, and fentanyl. These are the 4 available in our Indian market, and others are oxycodone and hydrocodone, which are not available here. So, whenever you are prescribing morphine or similar drug, first of all you have to assess the patient. What is the VAS score of the patient? What is the severity of pain of the patient? So, any patient having moderate to severe pain means VAS score from 4 onward, 4 to 6 or 7 to 8, 10, they need ENDs. And once you started prescribing essential narcotic drug from your clinics are not only pain clinic, but they are called opioid clinic, because now your focus has changed not only from pain management, but a special setting and special training is required to your team to handle the opioids. So, in your team you should have a psychologist also, a social worker also, and enough time is given to patient for evaluation and taking up the history and keeping the records, keeping the documentation. So, goal setting by physician and patient, that how much function can be improved, that is the first goal which is set whenever patient enters your pain clinic. Firstly, when you decided to prescribe a END to a patient, you start with the evaluation of the patient. First and foremost, intensity of the pain. Second is which medication patient presently is taking and what are the side effects, whether this medicine is effective or not. Whether patient has history of depression or hypothyroidism, then you should keep this in mind that these patients are likely to take extra dose of ENDs or might develop dependency on the drug. How chronic pain has affected his lifestyle, is there any disability, history of past and current substance abuse, that is very important. Is patient is taking opioid prescription from any other provider, like he is attending some other physician also and taking morphine. Personal or family history of drug abuse in patient like alcoholism or any other drug abuse history is given by the patient, and patient should be ready for any testing which is required. Whenever you are suspecting that a patient has abused the drug, he should be ready to undergo a urine test to decide the quantity of drug which is excreted in the urine. Before giving essential narcotic drug, one can use, there are many tools available to assess the potential substance abuse risk. The commonly used tools are K questionnaire, opioid risk tools and Dyer score. So, you can study one of the tools and make it whatever you are familiar with and keep it in your clinic. You can use that particular tool for all questionnaire. And no questionnaire should be very lengthy, otherwise patient will get bored and he will not be able to give a proper or correct answer. There are certain contraindication, relative contraindication for morphine use. It will not be, cannot be used for certain types of pain, treating the certain types of pain. First and foremost, without assessment of pain, you do not prescribe morphine. Only the morphine is given to the patient who are having moderate to severe pain. For mild pain, there are other drugs available. Patient having bone pain, nerve pain and colicky pain, they do not respond to ENDs or morphine. Pain which is not related to cancer like heartburn, peptic ulcer and anal fissures will not respond to morphine. Pain because of the gaseous distension, gastric distension, tenesmus will not respond to morphine, and incidental pain because headache and abscess pain which is because of infection will not respond to morphine. So, when a patient comes to you for the first time, he is having moderate to severe pain, suppose his pain score VAS is equivalent to 8, you have decided to give tablet morphine. Start with 5 milligram or 10 milligram morphine every 4 hourly. Morphine, the immediate release tablet is short acting, the half life is about 120 minutes and it is to be given orally. The tablets are available in 10 milligram, 20 milligram, 30 milligram. You can start with 5 milligram, that is half tablet morphine 4 hourly. Never prescribe PRN, means as per requirement it is not done, it is always 4 hourly. Add a laxative, this is very important. They say the pen which prescribes morphine should prescribe laxative as well, and the laxative commonly we prescribe for morphine is tablet bisacodyl. Bisacodyl 5 milligram, 2 tablets at night time. In few you might have to add antiemetics. Sometimes initially patient will get nausea, vomiting with morphine. So, add antiemetic like MSET or Perinome and tell patient to take for 2 to 3 days. Titrate the dose. Titrate the dose means increase the dose if required. If pain is not relieved with 5 milligram, you can after half a day or 1 day you can increase up to 10 milligram. So, titrate the dose till the pain is relieved. So, keep on increasing 5 milligram every time till the pain is relieved. So, what is the correct dose of morphine? The morphine is not, dose is not calculated as milligram per kg. It is always, it is the dose which reduces the pain of the patient. So, the correct dose of morphine is the dose that relieves the pain without causing drowsiness. So, in one patient it may be 5 milligram 4 hourly, another patient it may be 15 milligram 4 hourly depending on his pain. What if patient gets drowsy? Initially, if patient had long standing pain for so many days, he had pain and he came to doctor only after 15-20 days. So, 15-20 days he has not slept, he has lots of pain, and now if you give morphine he will immediately go to sleep. So, initially for 2 days patient may sleep little bit more. So, tell the relative not to worry, but he is rousable. Relative can arouse him and make him sit, make him eat, and again he goes to sleep. So, he is catching up from the lost sleep he had in past few weeks. But if this drowsiness prolongs after 48 hours or 72 hours, then your dose is little bit higher, which is causing too much of sleepiness in your patient. In this case, you reduce the dose bit. Suppose he is too much sleepy with 10 milligram, reduce it to 5 milligram. So, is there any there a maximum safe dose of morphine? No. Safe dose is that dose which relieves the pain of the patient without causing drowsiness. This is the gold standard statement. So, increase the dose in steps until the pain is relieved. Use the incremental 5 milligram, then increase to 10 milligram, 20 milligram, 30 milligram like that. Increase the dose every 4 hours if there is still pain, as long as pain is there, you keep on increasing every 4 hours. 90% patient will have relief between 5 to 60 milligram range. Most of our patients have pain relief within 5 to 60 milligram age. Sometimes total dose of morphine requirement is maybe as high as 500 milligram per day. In many of our patients, we have prescribed morphine 400, 500 milligram in 24 hours. Morphine tablet is available in two formulations. One is immediate release, which is short acting. Another is controlled release or sustained release, which is long acting. So, the sustained release or controlled release has action for 12 hours. So, in this case, this tablet should be given 12 hourly, only morning and evening. So, firstly we start the patient with immediate release tablet. This is immediate release tablet, these are short acting. So, we will come to know what is his morphine requirement. So, after 1 or 2 weeks, when his pain is stable, his dose requirement is properly calculated, he is stable with a particular dose, then convert it into the long acting formulation. So, he has to take swallow tablet only twice a day. So, how to convert that? So, if the daily requirement is 5 milligram 4 hourly, the long acting version will have 15 milligram tablet twice a day, 12 hourly. If patient is on 10 milligram, it should be 30 milligram. So, the equation is 4 hourly dose multiplied by 3 is equal to 12 hourly dose. So, suppose patient is on 10 milligram multiplied by 3 is equal to 30 milligram sustained release tablet 12 hourly, right. So, this is the table for of conversion, or you can just remember this formulation. Sometimes this happens mostly in our head and neck cancer patients. Initially when the disease is not much advanced, he is able to swallow orally, or maybe he is with a RAS tube, nasogastric tube, and medicine is given through it. But due to some reason tube comes out and disease is advanced. Now, you cannot put the RAS tube again, or patient is not able to swallow. In that case, you might have to switch over to another ENDs, essential narcotic drug, that is fentanyl patch. Now, your morphine patient is stable on 60 milligram morphine, but now his RAS tube is out, he is not able to swallow, you have to put it on a patch. So, how to convert from morphine to patch? So, these are the formulation for that. Suppose patient is on 45 milligram morphine every day, the patch requirement is 12 microgram. Fentanyl patch comes in terms of microgram released per 24 hours. So, if morphine requirement is 90, the patch strength is 25 microgram per 24 hours. So, this way you can convert to the patch and apply the patch. The fentanyl patch action starts after 12 hours. So, the day you apply patch, you have to continue oral morphine, whatever he can take, like you can put it sublingual or what, for up to 12 hours, and then the patch action will take over. In dose adjustment should not occur more rapidly than in fentanyl patch. We cannot change, once the patch is applied, the action lasts for 72 hours. So, you cannot do any changes in the dose up to 72 hours, and the minimal strength of patch available is 12.5 microgram and 25 microgram. So, if 25 microgram patch is applied, you want to raise up to the dose, you can apply another patch of 12.5 or another patch of 25 microgram, like that. Suppose a patient comes to you for the first time and he is having severe pain, he has not taken morphine or fentanyl or any other ENDs any time. Can you start all of a sudden morphine for the first time? Usually we go as per WHO ladder, first we put the patient on NSAID, then on second step we put the patient on tramadol, that is synthetic opioids, that is mild type of opioid, then put him on morphine. But patient has come to you with severe pain and immediately you have to start jump to the ladder 3. Is it possible? Yes, the answer is yes, because the aim is to relieve his pain, that is the first priority. In this patient, here I have described a small case report also. Bhikhubai, a male 63 years, is a known case of cancer of lung and presents with severe continuous pain in lateral chest and back. His wife gives history of giving various analgesics like diclofenac, whatever is available round the across the counter in large doses except morphine. He has not received morphine at all. How you will treat? Suppose if there is no venous access, then you can start injection morphine, which is available in many of the setup, 5 to 10 milligram intramuscular every 20 minutes till the pain is relieved, and then change over to double dose of morphine orally. Suppose he receives 10 milligram now, pain is not relieved, after 20 milligram another 10 milligram, 20 minutes another 10 milligram, pain is relieved. So, his total dose requirement is 20 milligram, but when you switch over to oral, you have to double this dose. So, you have to give 40 milligram morphine, 40 milligram morphine orally, right, 4 hourly. Similarly, you can give IV morphine also. You take 1 ampule of morphine, dilute into 10 cc. So, 10 milligram morphine diluted in 10 cc and inject 1 cc at a time every 5 minutes till the pain is relieved, and then you switch over to the oral morphine. Along with that, morphine action enhanced by giving non-steroidal anti-inflammatory also. So, you can give injection diclofenac, injection paracetamol and antiemetic. Suppose since you are giving such a large dose of morphine for the first time, patient may vomit. So, antiemetic drugs, and then start on the tablet morphine every 20 milligram every 4 hourly. Stabilize the patient, and another method which is available in this patient, since he is having CA lung in thorax chest wall. In tertiary care center, you have anesthetist around or pain physician around, and they can put epidural and relieve his pain instantly. Which is the best route of morphine? Morphine is a wonderful drug. It is effective by oral route, rectal route, sublingual route, subcutaneous route, intramuscular route, intravenous route, intrathecal, epidural, all routes it is very good analgesic. Sublingual dose is equivalent to oral or rectal dose. So, sometimes when our patients are not able to swallow or they are little bit comatose, then we give morphine sublingually, just 1 tablet or half tablet below the tongue. It gives very good analgesia. The dose remains same what you are giving orally. When changing from oral to oral or rectal route to one of the IV route, then you have to decrease the dose half. Tolerance to morphine is very interesting subject to discuss, and lots of research has been taken upon this subject. It has been observed that tolerance to morphine develops only when it is given in IV route continuously for long time. There are certain myths amongst the healthcare professionals also, as long as morphine is concerned, and even among the patient. One of my educated patient, he had severe pain, he had recurrence of the disease in the head and neck cancer, and I told him that it is now you will need to take morphine for your pain management. He said, "Madam, then what will happen in later stage? Why not to keep this in my end stage?" Because they have wrong myth that morphine can be given only when the patient is dying or when the patient cancer is too much advanced. No, sometimes we have to give morphine right at diagnosis also, because some type of tumor which are invading the nerve root or that particular area, then have giving severe pain, then you might have to start morphine right at stage 1. Secondly, among the doctors, it is a myth that if you start morphine early, later on he will require very large dose of morphine, because the patient will develop tolerance. Tolerance means patient will require to keep on increasing the dose of morphine as the duration advances. It is not so. A very good study has been done, a very old study, but where they have given very large dose of morphine over a long time to the patient, and they observed that there was no tolerance developed. Means same dose of morphine will relieve the pain of the patient. Morphine dose needs to be increased in at the time disease progresses, because of the disease is progressing, because he develops metastasis, because the tumor recurrence happens or recurrent tumor becomes enlarged and invades some vessels and nerves. That is why you need to increase the dose of the morphine. So, tolerance does not happen with the dose which we are using in our practice, like 60 milligram or 120 milligram per day. Second is, there is always fear that patient will become addicted to morphine. Answer is big no. As long as you have got, patient has got pain, moderate to severe pain, he will not develop addiction to morphine, and if you give morphine, he will not develop. But a normal person like me and you, who does not have pain and takes morphine regularly, we will develop addiction. And this is observed by, in certain situation, few of our patient, they are on morphine, and then we realize that he can be relieved with a nerve block, like a patient of CA stomach, he can be relieved by celiac plexus block. So, we take a appointment of CT scan department to do celiac plexus under CT guided, and after giving celiac plexus effective and pain relief is there, he is completely pain free. Now he does not require morphine, though he was taking 60 milligram morphine per day before block. Now suddenly we withdraw morphine, we just reduce the dose for another 1 or 2 days and then cut off morphine. In spite of that, patient does not develop withdrawal symptoms. This shows that patient does not develop any addiction to morphine. Another myth among doctors is morphine causes respiratory depression. This is what we have studied in pharmacology. But in one of the study, you will see that even patient with COPD, asthma like patients, whose respiratory drive is maintained by CO2 retention and all, even they, when they are having cancer and given morphine, they will they will not develop respiratory depression. In fact, Like my previous one of the talk of symptom management, respiratory symptom management, we discuss about giving morphine for dyspnea, patients who are breathless, because morphine will cut down the unnecessary respiratory drive and will cause make patient comfortable, decrease the respiration and decrease the breathlessness. So, these are the myths needs to be taken needs to be understood by all these facts, and one should start using morphine in their practice whenever required. This is already discussed. Is it too early to start morphine? No. You can start morphine as long as patient has pain, that is must. Relief of pain is primary importance rather than holding the morphine back for the future days. This was the study I was mentioning, that they studied pharmacokinetic of high dose of morphine, which is treated for long term with 10 to 20 fold increase of oral dose over a period of 6 to 8 months, and there was no change in pharmacokinetic of the morphine. This shows that patient do not develop tolerance with oral morphine. Few of the patient do shows intolerance to morphine, very few patients. Few of the patient has continuous nausea, vomiting because of gastric stasis, and they need to change over to some other ENDs. Few patients has excessive sedation, few patients has delirium and hallucination, few patients has myoclonus. One of my head and neck cancer patient, though he was in advanced stage, he had myoclonus of one limb only on morphine treatment. Vestibular stimulation, pruritus, which is also very commonly found but still manageable, and bronchoconstriction. So, in this patient this statement is wrong now, because now we have got methadone and fentanyl available for opioid rotation. So, in this type of patient you have to change over to another ENDs, stop morphine and put the patient on fentanyl patch or methadone. Now, it is available syrup methadone, which is 50 times potent than morphine, wonderful drug. Only it has got a effect on cardiac effect, and because of that it is to be used very cautiously. Frequent follow up, frequent ECG monitoring and electrolyte monitoring is required. So, there is always a scope for opioid rotation, we call it, change over from one opioid, one END to another END. Counseling of patient when you are prescribing morphine for the first time, counseling of patient and relative regarding the side effect of morphine is must and very important. How you can improve the tolerance? Start with low dose of morphine and slowly increase the dose. No, don't start with very large dose at a time. First you use short acting preparation like immediate release and then change over to sustained release. Sedation improves after 48 hours. Pain may appear to be morphine resistance if using underdose. So, check your dose whenever you feel the pain is not morphine resistance and patient is not improving, check the dose. Consider alternate opioid like tramadol, fentanyl, methadone, which is available here. You may consider interventional nerve blocks, which will reduce the dose of morphine requirement. Always discuss when your patient is not responding to ENDs, discuss with palliative care physician, they have got better knowledge of ENDs and they have handled oral morphine in almost they were there 70-80% of the patient. As I said, counseling and communication with patient regarding morphine is must when you are prescribing them for the first time. Firstly, first counseling is how you will take your medicine. So, you tell the patient to go to pharmacy, collect their medicine, come back to the department, and here the nurse or a counselor will explain them how you will take this medicine. Take the morphine 4 hourly round the clock. अभी हमारे गांव से आए हुए पेशेंट को इतना ही बोल देंगे कि एवरी 4 घंटे में लेना है दवाई, उसको समझ में नहीं आएगा. बट यू हैव टू एक्सप्लेन देम विच आर द टाइमिंग्स. In our hospital we have fixed the timings of the morphine given orally. Morning 7 o'clock, then 11 o'clock, then 3 p.m., then 7 p.m. and night 11 p.m. and middle of the night dose we combine over here and give double dose. So, these are the fixed timing. This is taught to each and every relative, every nurse, everyone. So, whenever they see morphine they tell the patient, अच्छा 3 बज गए अभी तुम्हारी दवाई का टाइम है. So, these are the fixed timings which are taught to patient. So, he will not miss the dose and his blood level will be maintained and he will have a good pain relief. Second thing, we explain about the side effects, and the first and foremost side effect is constipation, but this constipation is manageable. Firstly, as I said earlier, you always prescribe bisacodyl along with morphine. So, 2 tablets of bisacodyl he has to take every night irrespective of anything, unless he has got diarrhea. Secondly, you explain the relative that this will cause constipation. So, have change in diet of the patient, like giving more fluids. We tell them to take 1 glass of lukewarm water in the morning, take high fiber diet, and also thing is advice. Thirdly, tell the patient and relative not to use this tablet for any other person. Like अपने घर में वो हेडेक की दवाई होती है, सब लोग लेते हैं, like डायनापार और पैरासीटामोल. पापा को हुआ तो भी लेंगे, मम्मी को हुआ तो भी वही दवाई लेंगे. Here we will explain this medicine is for pain relief, but only for the patient, not anybody else should take, and it should be kept away from the children. So, these are all counseling we have to do, and next time when you come, you always bring the remaining stock of medicine. जितनी morphine बची है वो भी लेकर आओ, और उसके जो खाली रैपर्स है दवाई के वो भी लेकर आओ. So, we will come to know that patient has taken this medicine properly or not, round the clock or not, and missing, some medicines are missing, so it is abused or misused by somebody. This whole picture will be clear if he follows all this instruction. So, never to take all the tablets at a time. Morphine can be taken up on empty stomach, क्योंकि पहली दवाई 7 बजे लेनी है. Sometimes patient has not taken breakfast that time, so they will say मैंने breakfast नहीं लिया था इसलिए नहीं ली. Not like that. Half tablet or 1 tablet of morphine he can take on empty stomach. We also advise patient to increase or decrease the dose on their own, because half tablet, 1 tablet here or there, they have to adjust as per the pain of the patient. Suppose 7 बजे हाफ मॉर्फिन ली और 11 बजे तक रिलीफ नहीं हुआ, so instead of half at 11 he can take 1. Then breakthrough pain, intermittently suddenly कुछ पेन हुआ तो he can take 1 extra tablet of morphine for the breakthrough pain. So, all these instructions are given to the patient when they are given morphine for the first time. So, hospital can perform excellence when there is always care, comfort and the intention of cure is there as far as palliative care is concerned. So, this was in short about the how to prescribe ENDs. Only a systematic setup of the your clinic, systematic training of your staff, training of patient and relative, and that is the whole thing behind the success of your morphine prescription. And if you follow this system, your morphine patient will never misuse the morphine or abuse the morphine, and you will get patients coming to you during their next with smiling face and without any side effects and complication of ENDs. Thank you very much.